and I'm the Vice President of Public Policy at the Alliance for Aging Research, and I will serve as the moderator for today's discussion. Next slide, please. Before we begin, a few housekeeping notes for today's session. We've enabled live closed captioning of the webinar, which can be accessed by clicking the CC button at the bottom of your screen. Once you click the button, you can select Show Subtitles or Hide Subtitles from the menu to turn captions on or off. Next slide, please. At the conclusion of today's presentations, we will host a Q&A session. Participants can submit written questions at any time during today's event by clicking the Q&A icon at the bottom of the screen and then submitting a question through the pop-up window. Now, on the next slide, it is my pleasure to introduce today's panel. Bruce Pyenson is a principal and consulting actuary with the New York office of Milliman. He joined the firm in 1987. Bruce's practice uses data science and actuarial science to address pressing issues in healthcare. In his career, he has consulted to most every sector of healthcare, including accountable care organizations, employers, advocacy groups, insurers, and the biotechnology industry. Many of his projects involve integrating analytics from financial, clinical, and operational models. In 2016, Bruce was appointed as the Commissioner of MedPAC, the Medicare Payment Advisory Commission, serving in a position reserved for actuaries. Bruce is also an adjunct clinical associate professor of New York University's College of Global Public Health and a member of the Institute for the Healthcare Delivery Service at the Mount Sinai Health System. He serves on the board of the International Early Lung Cancer Action Program and was on the board of the Health Project, the Cooper Awards, from 2010 to 2016. Our second speaker is Phyllis Farrell. She is the global head of external engagement for Alzheimer's disease and neurodegeneration at Eli Lilly and Company, where she previously served as the leader of the global Alzheimer's disease development team. Farrell's most recent prior position was vice president of the chief commercial services officer for Eli Lilly and Company. Phyllis has been with Lilly for more than 25 years and has held many leadership roles throughout the organization. She has led efforts in medical affairs, medical development, commercial capabilities, sales, marketing, recruiting, business development, strategy, transformation, and corporate financial planning. Phyllis is a current member of the World Dementia Council, a steering committee member of the Milken Institute Center for Aging Alliance for Dementia Care, and of the National Minority Quality Forum's Alzheimer's Disease Index Working Groups, and a strategic reviewer for the Alzheimer's Disease Drug Discovery Foundation Diagnostics Accelerator. Third, Sue Peshin is president and CEO at the Alliance for Aging Research. Since 2012, Sue has been a driving force in the growth and success of the organization. Under her leadership, the Alliance has continued to build on its reputation as a forward-thinking public policy and health education organization. As a thought leader on many aging-related issues, she has led the Alliance in efforts to boost older adults' immunization rates, increase NIH Alzheimer's disease and aging research funding, increase awareness of geriatric cardiac issues, and it's helped develop the Talk Nerdy to Me program, which is PCORI funded and focused on older patient and family caregiver research engagement networks. Sue has also helped us develop ways to address cost of healthcare and evaluate value frameworks, and has also contributed to Medicare treatment access issues policy. Sue currently serves as the secretary and board member of Heart Valve Voice US and the King Farm Neighbors Village, an advisor to the ARCH Committee for the Advancement of Respiratory Research, as a member of the U.S. Pharmacopeia Council Convention, as a board member for the University of Maryland's Claude D. Pepper Older Americans Independent Center Community Advisory Board, as a council member for the World Economic Forum's Global Future Council on Healthy Aging and Longevity. I will now turn it over to Sue.
Hi, Michael. Thank you so much. Hi, everybody. Thanks for joining us today. Just real quickly, wanted to mention that the Alliance for Aging Research commissioned the report from Milliman in light of several Alzheimer's disease therapies that are or will be going through clinical development review and also value assessment. And as it says here on the slide, the report reflects the view of the authors, who are employees of Milliman, which does not endorse any product or program. And the next slide, funding for the report was provided by the Alliance, and we also received supplementary grants from Biogen and from Eli Lilly and Company. And it's now my pleasure to turn it over to Bruce Pienson.
Well, thank you very much, Sue and Michael. And before we begin, I should ask that people in the audience do not interpret anything I say as coming from MedPAC. All commissioners have made it clear that the only people that can speak officially for MedPAC are the executive director and chair. But this paper represents a lot of our thinking over the last 10 or 20 years. As an actuary, I've been involved in assessing technology, assessing the value of programs. And there are a number of issues with the traditional approaches that are used for assessing value and comparing the value of one technology to another. So a number of issues that are problematic and have struck me and others as problematic over a number of years. So I want to thank the Alliance for commissioning this paper, which really was able to bring together a number of issues and present what I think is a clear and practical alternative. Could we go to the next slide, please? I want to start by defining the traditional approach to value. And this often comes up in therapeutics. It's the term quality adjusted life years is often used for determining the value of a therapy. So if there's a therapy that costs $100,000 or one that costs $10,000, how do you determine which one is better, which one is more worthy of a payer paying money for? So that's the issue that ICER and other organizations seek to tackle, and they use an instrument called the quality adjusted life year, or QALY. And in simple terms, this is a numeric value, usually between 0 and 1, and 0 represents someone who's dead, and 1 represents someone who's in perfect health. And the QALYs are determined by surveys, asking people, typically healthy people, for a fair trade. Would you rather have 1 year being bedridden or a half a year in perfect health? If that's the case, then bedridden is assigned a utility of 0.5, and a whole series of these fair trades is collected, and databases are created of those, and that's the basis for thinking about cost effectiveness. How many QALYs does a treatment gain? Well, this has a lot of problems. Surveys, of course, change over time. Plus, surveys tend to reflect the status quo with all the disparities, systemic racism, and other problems that we have within our healthcare system today. So QALYs are not without their criticisms on a technical basis, but even arithmetic basis. But the traditional approach, which might work in some circumstances for a particular acute condition with a very clear treatment and a clear outcome that happens quickly, such as a broken arm, that approach works terribly for conditions like Alzheimer's, dementia, and other conditions. For one thing, the majority of cost for Alzheimer's is not medical spending, and assessing the value for a payer isn't really the same thing as assessing value for the patient or society. Another big problem is that QALYs and the traditional approach does not capture the impact on caregivers or the family. And as we know in Alzheimer's disease, most of the care is given by families and informal caregivers, along with a ecosystem of low-paid workforce. Qualies tend to preserve the status quo. As we know, ethnic and racial minorities are disproportionately affected by Alzheimer's disease in terms of incidence, but also in terms of a workforce and losses as people stop working to take care of loved ones. And finally, the qualies tend to miss a lot of the really important factors, quality of life issues that are important to patients and important to caregivers. And keep in mind how qualies are structured through surveys of mostly healthy people. So there's a number of issues. Let's go to the next slide to see what we've come up with as a set of principles. As we thought about this and thought about it from the standpoint of not just payers, but society and value, and of course, from an economic standpoint, not just a payer standpoint, but for society as a whole, we would like to emphasize that assessments of value should be independent of who pays and who gets paid. The challenge of immediately going from value to a insurance company is a real problem. Society has an interest in a number of things that are unrelated to payers. For example, most payers do not pay for long-term care, but society does. And that's just one of the kinds of challenges with that. A couple of other principles, three other principles that we think need to be stated that capture an ecosystem approach, because there really is an ecosystem that surrounds people with Alzheimer's disease. We need to use metrics that appropriately are the same, set the same standard, regardless of socioeconomics or age or the circumstances of an individual. What's good is good, it's good for everybody. We need to capture the health-related value of Alzheimer's disease therapies on family and other caregivers. Taking care of someone with Alzheimer's disease has been proved to create health burdens, mental and physical health burdens on caregivers and families. And treatments that affect that need to capture that value. And finally, the broader ecosystem surrounding Alzheimer's disease needs to be recognized. And as we change that system, that's of substantial value. Others have talked about how systemic racism in healthcare hurts everybody and more broadly in society. There's a similar ecosystem around Alzheimer's disease that needs to be addressed. Let's go to the next slide, please. So we think we have a better approach. I want to go through some of the details here. There's a lot of other issues that we could address, and happy to entertain questions later this afternoon. But one of the challenges with qualies in Alzheimer's disease or dementia or many other conditions is that quality adjusted life years are inherently ageist, because a quality, someone who has a shorter future lifetime has less to gain than someone who is younger. And that's a challenge with ranking interventions for people using qualies. The alternative is something that's gaining traction in the quality metrics world, which is that socioeconomics needs to be taken into account, and the value can be adjusted for differing socioeconomics, but the measures themselves of what's effective or what's not effective should be neutral to the socioeconomic backgrounds and the disparities and the differences. On health-related impacts of AD treatments, but not just for patients, there's sufficient evidence out there that caregivers, people with Alzheimer's, face their own challenges that are connected to their situation. And the clinical functional metrics that are often used in clinical trials, sometimes dictated by the FDA, are really not so much what counts for patients themselves or caregivers. So some of the activities of daily living are particularly important. That's where value comes from. Value doesn't come from the endpoints in clinical trials that might be there to obtain approval. The last item is to account for changes in the non-health outcomes, issues of community value. It's, as we've seen with the public health emergency and COVID, low-paid workers are associated heavily work in long-term care and the types of care that people with Alzheimer's receive. So there's a system surrounding Alzheimer's disease involving families and the workforce. And because Alzheimer's disease disproportionately affects Latinx populations, the ecosystem is complicated, and there's a lot of issues of disparities there. We don't want to sustain that system inadvertently through the metrics we use. So those are the some background. Some of our thinking is a lot more detail in our paper. Encourage you to take a look at it. Let's go to the next slide. Well, some of the proposed solutions, I think, for QALYs, and there's a lot of dissatisfaction with them, aren't really going to solve the problem. We can't easily create add-ons to take into account caregivers and community and things like that. We really need a new start along the lines that we've proposed. There's a number of analogs in society and how we fund societal values. Relative social willingness to pay is one. Corey is exploring items, and Sue's going to talk about that. And Germany has a broader approach to determining value. So there's a lot of analogs that we can think about, and we mentioned some of those in our paper. Work needs to be done. It needs to start now to define the burdens and define the value that society gets from solving those challenges. And again, to separate the concept of value from who pays and who gets paid. Well, thank you very much. Going to hand over the virtual microphone to Phyllis Farrell, who's going to give an industry perspective.
Hi, Bruce. Thank you. And a big thank you to the Alliance for putting together this, this collaboration, and to the Milliman team for a really fantastic report. So I am here giving an industry perspective, but I would be remiss if I didn't say that I'm also giving a family perspective. Like most of the people that are on this webinar right now, your families or friends' families have probably been touched by this disease. And as I read a lot of the pieces in the Milliman report, it made me think about my own family's journey with this disease and what would have been valuable and important for us. So let me start by saying that we completely agree that Alzheimer's disease is different. It is one of the several diseases, very few, where the vast majority of its impact is actually on families and communities. Its burden is outside of the traditional healthcare system. So rather than the cost being able to be measured in direct medical costs, payer systems, health insurance systems, we can't find those costs right now. In fact, I heard it said, and I completely agree, that the current standard of care for Alzheimer's disease is the family caregiver. And that's what happened in my family as well. I'll never forget the day when we got my father's diagnosis and the physician looked at me and said, "You now have two patients, not just taking care of your father, but watching out for your mother's health, because she also is going to be caring for your father." And we did watch her health decline and did everything we could to help support her. And yet we know now from much data that caregiver health impact and healthcare utilization is impacted by an Alzheimer's diagnosis in a loved one. That's not something that we are able to collect very easily. So we agree that determining value in Alzheimer's disease needs to include all three perspectives: the patient, the caregiver, and of course the payer, but also that societal perspective. Traditional value methodologies are typically applied from a payer lens, and they often ignore or underestimate the impact of the treatment on the caregiver burden, which is just enormous in Alzheimer's disease. We know that there is some recognition for thinking about societal-based care in some other methods, but we really recognize the Milliman perspective here to push that even further. I would also be remiss if I didn't echo the words of Bruce and ask you to read the executive summary, if nothing else, in this report, because inclusiveness is especially important with regard to social determinants of health, given the disproportionate impact that Alzheimer's disease has on women and people of color. And we applaud the author's suggestion that methodological changes should be identified that address the indirect costs of societal harms of these disparities. The impact on caregivers is significant, and it can have a generational impact on wealth and family stability. Right now in the United States, when we're rethinking so many things about our country and our systems and potential micro inequities, why are we not doing it as well for how we value these therapies? In our family, we had means. My sister was able to quit her job in order to help care for my father. Not many families can do that. How are other families going to handle this battle? It was hard for us. So QALYs, something that I'm not a health economic expert and have learned a lot about here recently. We know that they may be necessary, but they are rarely sufficient. And they're certainly not sufficient here in Alzheimer's disease. Of course, no one will question the importance of survival or quality of life, but the way QALYs are defined and measured have radical limitations that are particularly problematic for Alzheimer's disease patients and their families. They give a lower weight to treatments for diseases that are concentrated among seniors, because by definition, they yield fewer gains in life years. They give a lower weight to treatments for diseases that come with significant quality of life burden from other diseases and may not improve. And they give lower weight to treatments that do not extend life, but only ameliorate quality of life. And I think about this particular instance with my mom when I asked her how she was doing. And she said, "Oh, I'll be fine. As long as it stays like this, we will be just fine." But I knew, I work in Alzheimer's research. Alzheimer's disease is a progressive neurodegenerative disorder. It's not going to just stay like this. We need therapies that are going to help things stay as close to like this as they are, and we need value mechanisms that allow those therapies to be valued. We agree that value assessments have to take a more holistic approach. They have to include a broader array of value measures beyond the QALY's two elements of survival and quality of life. They have to take into account patient perspectives on the improvement of diagnosis, cognition, and the ability to just stay the same if it's at all possible. Caregiver health impact, caregiver quality of life, and the economic consequence of pulling people out of the workforce should also be considered. There's examples of increased productivity and well-being, care experience, reduced health inequities, and ethical considerations that really need to be included in valuing therapies and diagnostics for this deadly and dreadful disease. We agree with the author's recommendation of the informed judgment approaches, such as multi-criteria decision analysis and deliberative appraisals. These methods are not merely open discussion or intuitive judgments. They provide pre-specified ways of including quantitative and qualitative measures of value. For me, MCDA and EDPs are like consumer reports for healthcare payers and value assessment organizations. Consumer reports combine both quantitative ratings and qualitative perspectives to help consumers make informed judgments on which product provides the best value for their circumstances. If we can do it in consumer products, why can't we do it here in healthcare? So in conclusion, the complex nature of Alzheimer's disease requires a suite of measures to fully assess the benefits of diagnostics and treatments from Alzheimer's disease, and they have to include the perspectives of the patient, the caregiver, and of course, society and the payer. And just as our society realizes that we need to take a more holistic approach to health and wellness, we also urge organizations and decision makers that assess the value of these potential treatments to take a more holistic approach as they assess value. Once again, with everything else that we're considering in our society today for micro inequities, why would we not also reassess the way we value our Alzheimer's therapies and diagnostics? We're really proud to have been part of this project and really thankful to the Milliman team and to the Alliance for Aging Research for their work on the report. Back to you, Sue.
Thanks, Phyllis. That was fantastic. Really appreciate you, expressing your personal experience as well. I think it's always important for us to tell our stories. I have had dementia in my family as well. My great-grandmother had it, and I took care of her with my mom into my teen years. So it's a pleasure to be with everybody today. I'm going to talk about why it's so important for people to understand and weigh in on value assessments for new treatments, and then touch on a bit about how to go about doing it. Next slide. Some of this Bruce brought up, but I'm going to unpack it a little bit more. And also Phyllis talked about it a little bit too. So we know from Bruce that the quality adjusted life here, which is known as the QALY for short, is a health economics measure, which theoretically represents the degree to which a treatment extends life and also improves quality of life. And as he mentioned, but I'm going to talk about a little bit more, QALY assessments assign a value that's called a health state preference value to the patients a treatment is intended for. And you can see in the chart below what I'm talking about. And these assessments are based on the perceived value of living with a given condition in comparison to being in perfect health. And as you can see here, these preference values assign a value to a human's life on a scale between 0, which is death, and 1, which is perfect health. And as you can see here, it's also possible to rate a health state worse than death, like ALS. An older age, if you look you look all the way to the right and just a little bit to the left, the second green dot is 0.7. That's if you happen to be older than 80. So you're not a 1 anymore at the age of 80. So the QALY is calculated by multiplying this value with the time the patient is likely to spend in that state. So as an example, if a 30-year-old and a 60-year-old get identical treatments for a fatal disease, which results in a 100% cure, and they're expected to live to about 80, it's 2.5 times more cost effective to treat the younger patient than the older one. So by definition, QALYs undervalue treatments for populations that have fewer expected years of life left or shorter lifespans than the overall population. And why did I put theoretically in parentheses? Well, there's a lot of factors that can impact these values because they reflect the preferences and prejudices of the people who develop them and the people who are asked to rate them. So for example, did the preference survey ask people who have the actual condition for their perspective, or did they ask people who've never had that condition or never even knew anyone with that condition? So when someone says the treatment is worth X amount per QALY, now you know what's being talked about can be kind of arbitrary. The actual impact of this is really big because if a treatment is for a group that's sicker, older, or includes people with disabilities, or if it's focused on a population that has historically faced inequities in society and in our healthcare system, the treatment is generally assessed as being less valuable. Or another way of saying this is that those groups are considered more expensive to treat. By concluding that a treatment isn't cost effective, insurance companies can then justify restricting access by not covering it or by using management techniques that effectively restrict access to it. Next slide. When QALYs are applied to value assessments for Alzheimer's disease treatments, it really presents a moral quandary due to older age and health status. If you look at the 6.2 million Americans age 65 and older that are living with Alzheimer's, 1/3 are over age 75 and another 1/3 are over age 85, meaning Alzheimer's medicines would be expected to receive lower QALY scores. If you pile on comorbid conditions like diabetes, coronary artery disease, and heart failure, the preference value is likely to go down even more. And QALYs also don't value symptomatic treatments that may only improve quality of life, but not length of life, as valuable as disease-modifying treatments. And then to add insult to injury, QALYs also don't generally recognize the significant burden of Alzheimer's disease and other types of dementia on family caregivers and society, which means that they also don't recognize the value that treatments have to alleviate those burdens. Next slide. So most people say history is a very good teacher, and the National Institute for Health and Care Excellence, also known as NICE, was set up by the UK government in 1999 to perform QALY-based cost effectiveness assessments for new treatments and tests. And then they give recommendations about whether and in what circumstances the technology should be used by the National Health Service, which is essentially the country's health insurer. In 2005, NICE proposed that cholinesterase inhibitor drugs for the treatment of dementia, like Aricept, should be banned to National Health Service patients on the grounds that their cost is too high and, quote, outside the range of cost effectiveness that might be considered appropriate for the NHS. And this was despite NICE's admission that these drugs were effective in the treatment of Alzheimer's disease, and despite NICE having approved even more expensive treatments. So you could have something, a new therapy that's approved by the FDA, considered safe and effective, but might not be considered cost effective. So it's important to remember that at this time that I'm talking about, there were no other available therapies to treat AD. So it wasn't the drugs that were judged to not be cost effective when compared to rival treatments. It was the patients who were being condemned as not cost effective to society. And why were the patients not cost effective to treat? The only answer must be that they really weren't worth helping. If it was simply on the basis of cost alone, If they simply couldn't afford the drugs, that would be one thing, but NICE said the drugs were not cost effective in quality terms. So now you have a concrete example. So even though the US is increasingly considering embracing the quality, ironically, NICE's new chief executive, Gillian Lang, is reconsidering it. And she says that dealing with COVID-19 has brought a new lens to the use of QALYs in the UK, in a lot of different cases, but especially having gone through COVID, where people are suffering from a life-threatening condition, but not yet dying. So does that sound familiar to you in our discussion about Alzheimer's disease? It's really maddening to me to think that the US may be going toward the QALY as other countries who have been using it for decades may be moving away from it. Next slide. So what do QALYs and NICE have to do with you guys weighing in on an Alzheimer's treatment? Well, there's an organization that's called the Institute for Clinical and Economic Review, or ICER for short, and they issue cost effectiveness reports on new treatments. Health insurance companies use ICER reports to decide whether a treatment is worth the cost of covering it, or if they should design barriers to make access to the new treatment more challenging and help the insurance company save money. ICER uses QALYs in their analyses. Actually, they made up a new version that they call the equal value of life years gained, but it's essentially the QALY with upper and lowercase letters. There's a few things that you need to know about ICER. One is that there's little transparency into ICER's formulations and how they arrive at their conclusions. And that means it makes it hard for other researchers and even payers to analyze and replicate ICER's results. The second is what I call the tough noogies approach to their methodology. That's their attitude. The former chief scientific officer at ICER recently wrote an opinion piece in which he said the QALY cannot capture all of the nuances and challenges of living with a certain condition. So ICER reports note that they aren't able to account for health disparities or if certain groups of people have shorter lifespans. So if you don't like their methodology, tough noogies. And they also have a tendency to use patient groups. And I mean that sometimes in a not great way. ICER asks patient groups to weigh in on their work, and they use their involvement as an endorsement a lot of times. And they also, on the other hand, can sometimes engage in attacking them. Some patient groups have a very decent experience with them, but many groups have had a tough time. And in fact, this week, this Thursday, a group called ISPOR, which is the International Professional Society for Health Economics and Outcomes Research, is hosting a panel to discuss whether patient groups that take industry funding can be considered independent. And ICER's VP of Patient Engagement is a featured speaker there. So that kind of speaks for itself. Next slide. ICER released a draft evidence report in early May on a new AD treatment, aducanumab, which I know a lot of you are familiar with. And you can view the report on ICER's website at icer.org. You can go to explore our research and then click on assessments. And when you scroll down, it's the first assessment that's listed. And if you click on it and then scroll down and click on full timeline, the press release for the draft evidence report has all the info. You can submit a written public comment on this draft evidence report until the end of the day on June 2nd by email to publiccomments@icer.org. And just so folks know, we're gonna make these slides available so you'll be able to see this information. And I'm also gonna talk about an organization that can also help out in just about a moment. ICER is also holding a virtual public meeting about the report on July 15th, and you can register to attend. And during the virtual public meeting, there's going to also be a limited amount of time available for people who are interested to make an oral comment on the report. Requests to submit oral comments are, emailed to the same place to submit a written public comment, publiccomments@icer.org by the same day and time, June 2nd, end of the day, 5 o'clock. It's really important for as many patient and family caregiver advocates to weigh in here in all these different kinds of ways. You can use Milliman's new report, use some of the points we brought up today, and most importantly, use your personal experience with Alzheimer's disease because nothing tells it better. Next slide. Luckily, there's also awesome resources at the Alliance for Patient Access, which is a national network of physicians, and they're dedicated to ensuring patient access to approved therapies and appropriate clinical care. And they put a toolkit together on all of this, and you can also reach out to John Bates directly at jbates@allianceforpatientaccess.org, or you can check out their toolkit at instituteforpatientaccess.org, then a slash, then ICER-Alzheimer's-report. And again, we'll send these slides so you don't have to memorize any of that. And then next slide, for anybody who's here from Talk Nerdy, which is the Alliance's patient engagement and family caregiver engagement program, you can also reach out to me or to Sarah. I know you guys know how to get in touch with us, but here's the info. And thanks so much, everybody. We're glad you're here.
All right, thank you, Sue. And we'll now move on to the Q&A portion of our discussion today. And just as a reminder for the audience members, if you want to submit any questions for today's panel, just click on the Q&A button at the bottom of your screen. Then a pop-up will show up that you can type in your question for the panel. So I'll start with a question for Bruce and just ask, for Bruce, for beneficiaries that are eligible for both Medicare and Medicaid, I know there's been a lot of discussion over the years kind of about the integration of those benefits, but would better integration of those two programs make a difference in assessing value for patients that have Alzheimer's?
Well, it would certainly make the life of patients better. The disconnects between the acute care services that are covered by Medicare and the long-term care services covered by Medicaid are one of the legacy problems of the way that our healthcare system has evolved. But I should actually call on my co-authors and recognize them, Pamela Pellizzari and Rebecca Smith. Pamela, Rebecca, do you want to address that issue?
Sure. I mean, I think one of the, as you pointed out, would be better for patients. But I think one of the main things that we pointed out in our paper is that until we're looking really holistically at all of the costs and impacts on patients and sort of stepping away from where the actual costs are accruing to and just sort of taking a step back and looking at value, just the value overall, and then figuring out how to allocate that value or allocate those costs, we're never really going to get to the bottom of the issue here. So I think certainly it would be helpful, but there's that, as Bruce had mentioned earlier, that issue of separating value from who's paying for the solution.
Great. So Phyllis, I'll ask you, I know that there, obviously you talked about disparities in the report, but want to ask you kind of for your insights on how communities of color are disproportionately impacted by Alzheimer's disease, and do those differences affect access to treatments?
Thanks, Michael. I think it's so important. So we know that African Americans are 2 times more likely to have Alzheimer's disease, and the Latin population in the US is 1.5 times more likely. I think we're still trying to get under the research there to understand if that's genetic or if that's primarily related to social determinants of health and other complicating factors. But we know that this is a problem in the healthcare system today. There's actually recent data from several publications that show that African Americans, people of color, are less likely to have a cognitive test even than their white counterparts, which is crazy because it's pretty low for white people too. But secondly, that they're often not, the diagnosis isn't shared with them. So, across the board, a diagnosis of Alzheimer's disease is only shared 30 to 40% of the time, and it's even less in the case of people with color and underserved populations. And you think about what's going to happen. I mean, what is going to happen in this disease is really predictable. Someone is going to fall, someone's going to wander, someone's going to have an accident, and it is going to cause a financial crisis for the family. And the fact that we're not having these conversations with people in advance of those crises so that they could potentially get the services and support that would help them through one of those crises, or even potentially, prevent one, is crazy. So I think it's really important, because all of this is tied up together in how we value a diagnosis, not how we value a diagnostic, but how we value a diagnosis and how we value a therapy and a treatment. And do we say that we want to get out ahead of these things for families so that they're not facing these crises? It's hard on a family like ours, and we had some buffer. I don't know what you do if you're a family that doesn't actually have any buffer.
Yeah, no, it's such a critical issue. And Sue, I know that you kind of point out a number of the challenges with traditional value assessment. And really, I think there's maybe a growing recognition that the traditional way isn't necessarily the finish line of value assessment, that there's more work to be done. So I wanted to ask you if if there are alternatives that are ready now, or if there's research that's ongoing into kind of new ways of thinking through how to do these value assessments.
Yeah, thanks, Michael. And before I answer it, I just wanted to say to Phyllis, there's an ethicist, John Harris, who's actually from the UK, and he's written about this. And he talks about how the use of QALYs kind of distorts our ethical way of thinking, because it directs us to focusing on life years instead of the person's life. And that's kind of what you're talking about with the difference between the diagnostic versus the diagnosis. So I agree with what you said, Michael. Definitely the Milliman report, we're so grateful for it. Very practical in the framework, but there's a lot more that needs to be done to reframe value. And we really want to see a reframing in a way that better captures, number one, what matters to patients and to family and caregivers, and two, what emphasizes access as the starting point instead of the end point. Because when you leave it until the end, not too many folks are able to get new therapies up front. So Phyllis mentioned cost-benefit analysis, which really looks at whether the benefits outweigh the costs of a given treatment. That's one of the approaches that's mentioned in the report. Multiple criteria decision analysis is an example of that. I'm not going to kind of go into it, but the idea of, do the benefits outweigh the costs? It's a different way of looking at it than sort of sizing up the individual that's going to be getting the treatment. And then relative social willingness to pay, that looks at an individual's willingness to pay for a service related to another service. So if you were going to go to a nursing home versus getting this treatment, this costs, X, this costs Y, taking a look at those types of things and looking at it from a broader social perspective. And these different ways of looking at things are also better able to just sort of have a more complex paradigm to them, so you can integrate things like social inequality. And then last, and there's other examples as well in the report, so I encourage people who are interested in this to check it out. But last, Bruce mentioned the Patient-Centered Outcomes Research Institute, or PCORI, which is an independent, nonprofit, non-governmental organization in Washington, D.C., and it was authorized by Congress in 2010. And PCORI is really the number one private funder of comparative clinical effectiveness research, which is research that compares the benefits and harms of alternative treatments or care delivery. And they do it from a patient perspective, keeping, sort of all stakeholder points of view in mind. PCORI was given further authority by Congress in 2020 to fund research that considers economic impacts. And just this year, they put out a report and had some principles in there to consider those types of outcomes. And so I'm very excited to see what they do with that. We've weighed in on it, and other groups should as well. And then the one last thing I just want to say is what we don't want. And we don't want to replicate NICE. We don't want international reference pricing where we're importing other countries' pricing that may in the short term drive some program costs down, but are really going to restrict access for patients, going to restrict innovation. So even though it's sort of shiny object right now to look to other countries, I think it's important for us to sort of learn from what other countries have gone through and then, reevaluate what we're doing here as a way to envision value in a more expansive way.
Thanks, Sue. And I'm just going to point out a couple of comments that have come in through the Q&A box, not necessarily questions, but I think some insights. Ian Kramer notes that part of what makes ICER's disregard of real-world economic impacts related to family caregiving and Alzheimer's disease so problematic is that, especially in communities of color and lower socioeconomic status populations, multi-generational caregiving results in many school-age children being compelled to play significant caregiving roles, which threatens their own educational attainment, their earning prospects, and their own risk for later developing Alzheimer's disease. Also, Margaret Lehman notes that there's some work going on in developing care models around Alzheimer's disease. The Alzheimer's Association has developed a proposed dementia case management model, and UCSF has a system care model that's worth that people looking at as well. So I know we're coming to the close of our time, so I just want to provide an opportunity for Bruce, Phyllis, and Sue to provide any kind of closing comments that you all may have as we wrap up today.
I can start with one, and I think I would just say that it's wonderful that we're sitting here having a conversation about valuing a therapy. We haven't had a success in Alzheimer's research in 2 decades. And when we look at the healthcare that comes today for people that are facing this disease, it's the same that was being offered to our grandparents and our great-grandparents. And so the fact that this science has moved to a place that we could actually be really having this conversation about valuing a therapy is just worth celebration. But on the other hand, that gives us, the motivation and the urgency to make sure that we change the way that we value these therapies, because what a tragedy it would be if we finally get over this scientific hurdle and the people who would most benefit from these therapies and this innovation weren't able to get it.
Mike, just a thought, if I could, that the issue of value is critical for the country. We are spending way too much on healthcare, way more than other countries, and our outcomes are substantially worse. The Part A trust fund for Medicare is running out of money. So figuring out what is worth spending money on and what isn't is a critically important issue. Qualities aren't the way to do it, but we do have a challenge in this country of a lot of care and systems of care that are not worth what we're paying for.
Excellent. I salute both of you. You guys are amazing. Thank you so much. And Bruce, to you and your team for the exceptional report. We really appreciate it. I would just say, Michael, that just in response to Ian's insightful comment, as always, it's really true. It's important to understand that this is not just sort of a one and done for one, type of treatment for one disease. It is a systemic sort of infrastructure issue, and our attention is a bit more focused on health equity these days, thankfully. And this is a big health equity issue. This is a big issue of, discrimination that we need to face at the basis of health economics. And we have an opportunity here, I think, coming off of COVID, to reflect and reconsider. And as I said, to be more expansive and consider the patients, consider the families. And I remember learning this from Bruce when I was first getting into this, considering how we want to be as a society, really. That's really what it comes down to, because it's a reflection of who we are.
Thanks, Sue. And as we draw to a close today, I just want to share with the audience that a recording of today's webinar and the slides will be made available very soon to you all. And so we'll make sure that you all have access to that. And that'll be available on the website at agingresearch.org. And also encourage everyone to check out the FPA toolkit for commenting on the current comment period open for Alzheimer's assessments with ICER. So I guess in closing, I just want to thank everyone here today, both the panelists and to today's audience, for this really robust and illuminating discussion. It's essential that we all work together to find a cure for Alzheimer's, which has really an incalculable human and financial cost. So this discussion is ongoing, and we look forward to continuing it as we move forward and towards finding effective cures for families and caregivers and the patients that suffer from this disease. Thanks so much, everyone.
Bye, thanks.